Thank you so much, and it's wonderful to be here with you, looking back over these last 20 years and celebrating the progress that we've made together. As I looked back, thinking about today, and looked over the last 2 decades, I think together we've made care better, we've made it safer, we've made it more effective, and yet we still have a long way to go. So I'm delighted to have everybody here in the room thinking not only about how to celebrate the last 20 years, but how to think about what's still to come. When I was thinking about how healthcare has changed in these last 20 years, it's really quite amazing. When you think about technology as an example, technology is a part of many patient and physician interactions. We're looking at care that's being given by new people in new places, even looking at personal devices. Now, we can look down at an individual patient and find out how many steps she walked yesterday or how many hours her husband slept last night. So we're looking at data at an individual level. We're looking at small data. We're looking at data at a population level. We're looking at big data. And we're now looking at long data, where we can look back and look at how do we need to change care in order to provide the best health for everybody in our population. So small data, big data, long data. And I think most everybody in the world today is beginning to think about the triple aim as their goal. As I travel around, I'm hearing everybody thinking about the health of the population, about creating better experiences of care, and really identifying where we can balance costs out in the best way. So I've spent a lot of time looking back these past couple of weeks and getting ready for today, and I actually got quite nostalgic. I was thinking back to my earliest days and what it was like for me when I was a nursing student, when I was an early nurse just a few years ago. You weren't supposed to laugh. But I was thinking back to what it was like, and I was really excited to have all of the students here today, and I really do want to talk to them. As Fiona said, we have almost 100 students, and I'm going to ask all of the students in the room to stand up so we can celebrate what you're bringing, the energy and the passion that you're bringing. So would you all stand up, and we can celebrate 100 people. 100 people who are beginning their journey. And I really do want to talk to those students today. The reason is because you face change like I never did. As much as has happened in the last 20 years, change is happening so quickly. And so I'm really a little bit worried about the students here. And I really do want to focus on you. What I'm seeing, research is showing that by year 3 of professional education, many students are reporting exhaustion. Some call it burnout, physical fatigue. They're losing their resilience, and they're losing their empathy. And as you remember Francis Peabody saying that the secret of the care of patients is in caring for the patients. So these young students who are devoting their careers to taking care of people really need to be able to work in systems that are vibrant, that are supportive. They need to be working with resilience and with joy, with skill and expertise, and with caring teams who are everybody helping together so that they can work forward and take care of people. So I'm going to talk to you today, but I think the messages may resonate with everybody. And what I want to talk about this morning is a toolkit. I've been thinking about what are the tools that we could all build to create joy for the students, to create empathy and resilience in all of us so that we can provide the best care for patients. And the first tool I want to talk about is curiosity. So I want to start by telling you a story. A few weeks ago, I was driving to work, and I was listening to National Public Radio in Boston, and I heard a story about a physician whose career was so interesting that when I got to work, I looked up her telephone number and I called her. Her name is Nancy Hart, and we have spent hours on the phone the last few weeks, and I've been really curious about her journey. Nancy started off as an OBGYN, high-risk OBGYN. And she was really good at it. Every day she'd go to work and she'd order amniocentesis and biophysical profiles and antenatal testing and ultrasounds. And she was really good at taking care of these preterm babies. If you take a look at the data, and she did, the human cost of preterm births or low birth weight babies is huge. An infant mortality rate is 70 times higher for a baby who's born too early. And that's the human cost. If you look at the financial cost, the average medical cost for a baby in the first year of life who's full term is $5,000 in the US. For a baby who's born preterm, it's $55,000. So Nancy was every day taking care of these patients. And one day she stopped to say to herself, I'm really good at what I do, but why am I not preventing this from happening? And so she decided to step out of her role as a high-risk OBGYN, and she went to Washington and did some policy work, and then came back to Florida. And in her work in Florida, she began to, again, take care of patients, but this time she was at the end of life. She started to do pathology. And one day, she started to be curious again. She noticed that there were 450 babies born into poverty in 1 square mile of Gainesville, Florida. And when she thought about it, she had always thought that that part of town was affluent. And so she started to think, why are there so many babies born into poverty? Why are there so many preterm births in this part of town? Why are there so many preterm deaths? And so she made a map, and she started to look at the hot spots on her map. Once she put her map together, she started showing it to her physician friends who were colleagues, and she said, why do you think this is? And nobody could figure it out. So they told her to go and talk to the hospital CEO, and she did. And he said, you need to go and talk to the sheriff. And she said, why do I need to talk to the sheriff? Nancy confessed to me that she was a little nervous about talking to a sheriff because she said the sheriff has a gun. And when the CEO went to talk to the sheriff and asked him to meet with Nancy, the sheriff said, I'm a little nervous because the doctor has a brain. And so here are these two people who are coming from very different places, and they decided to get together and put their maps together. So Nancy showed the sheriff her map, and the sheriff kind of smiled, and she pulled out her map of domestic violence, of vandalism and crime. And when they put the maps together, the maps were almost identical. So Nancy said, why is this? And the sheriff said, you need to come with me. So she put Nancy in her car, and they drove to the neighborhood where all of these babies were being born into poverty and born preterm. What they found was that the two people looked at the exact same thing, and they had different labels for it. They would look at a kicked-in door or broken windows, and Nancy would say, that's domestic violence, and the sheriff would say, that's vandalism. So they were looking at the same thing, but they couldn't find common language or common ground. So they began to work with the population there. And Nancy asked many of the people living there, how do you get your health care? And they said, we don't. They said, it's a 2-hour bus ride for us to get to a clinic. And getting all my kids on the bus and going 2 hours each way, it's just impossible. So basically, they wait until a chronic condition becomes grave, and then they end up in the emergency department. So Nancy and the sheriff decided to become a team, and they began to, I will say, coerce business people and the mayor in the community to give them a bus. And they started a mobile outreach clinic. The clinic is amazing. It's got 3 major goals, which I thought was really interesting. The first mission, although it's at the bottom here, is to take care of patients. It's to bring health care into a community which is desperately in need of health care. The second mission, though, is to create joy in work. Nancy said, we've got to create a culture of service. That's why we all came into healthcare. But so much of our staff have become burned out by long hours and the rate of change and the burden of managing very sick people. So many of them have lost the culture of service. And then my favorite one of all is, she said, we need to teach the young. We need to reach out to all the students, the ones who are here in this room, and make sure that they come into healthcare with the most vibrant and resilient systems around them so that they can provide good care. So Nancy, the high-risk OBGYN/pathologist, is now teaching quality improvement to the students. These students get credit. They get college credit at the University of Florida for their medical school, their nursing school, pharmacy programs, by coming and taking care of patients on the van. And they find amazing joy in this work. These students, actually, Nancy told me, they're in Florida, you know, where the beaches are, give up their vacations on the beaches to make sure that the van is staffed every single week of the year. That's how dedicated and how committed they are to these patients who they're caring for. So Nancy got curious again, and she asked the students, what lessons have you learned from taking these courses, giving care on the van, that you didn't learn in your traditional medical curriculum? And these are the reflections from the students. They said these are things that nobody ever talked to them about. How to do a local needs assessment, how to understand the health and the social needs of everybody in the community, how you can diagnose intimate partner violence. They never learned how to do that. They learned about food insecurity and how to match people up with resources. They learned about literacy, and they learned about cultural differences. They learned about how to provide connections to people who needed dental care or mental health. None of this was in their normal curriculum, but they feel so empowered by having this experience that they said this idea of working on the van should be absolutely mandatory for every person going through clinical education. So Nancy became curious, and she started to solve problems that were way outside of her purview. But it's that curiosity, and I want to come back to that, because a lot of times when I'm talking about curiosity, I'll see people who are in burned out roles feeling like, I can't lift my head up, I can't be curious. I've already got so much weighing on me right now. But I want to tell you that being curious won't weigh you down. Being curious will build you up. Being curious will give you new perspectives and new energy. I don't know if you read the recent Harvard Business Review on the importance of curiosity. And the authors were talking about the intelligence quotient. And as you know, everybody knows what IQ is. It's the ability to process complex problems at speed. And most everybody knows what EQ is, emotional quotient. That is, do you have empathy and sympathy? Can you work through the emotions of the people that you're caring for or with? But I think most people haven't been working on their CQ, which is their curiosity quotient. And that's a way to think about your success as a student, your success as a clinician. It's how to build your CQ, and that is to open up your eyes to looking at different perspectives. Now, if you come to IHI, and I hope you will, what you will see, all right, I'll say that oftentimes you'll have to go to the restroom, and if you walk into the restroom at IHI, this is what you see. And people walking into the restroom will often say, oh, they made a mistake, there's something wrong. There's something that didn't go right in the ladies' room or the men's room. But by the time you're washing your hands on the way out of the restroom, this is what you see in the mirror. You see a beautiful quote that says, by looking at a problem from a different perspective, sometimes the solution is clear. And so what I see is people walking into the restroom and getting puzzled. They don't have a high CQ, but when they turn around and look in the mirror, they walk out with joy. They walk out with a smile on their face, because they realize that looking at a problem through a different perspective is exactly what we need. That's building your CQ. So we've got, I think, a lot of work to do in building our CQ. If people are feeling burned out or down, what we've got to do is really open ourselves up, and that's sometimes hard to do, but I think together we can make that move. The second tool I'm going to suggest in your toolkit is learn improvement. Build your own improvement skills. And this is so important because what I find that it's really a failure of leadership to be using transparent data and posting your rankings, but not giving you improvement skills to close those gaps. It's a failure to me when leaders are posting rankings and ratings and showing you this is where you stand, there are huge gaps in your performance, but without giving you the skills that you need to close them. So I'm going to say the second tool in your toolkit is to really learn how to improve. Now, there are many tools, there are many ways to do it. The IHI Open School, many of the students here, we've got about 233,000 students in 70 countries that are learning improvement along with medical school curriculum and nursing school curriculum. And that is incredibly engaging. What I find is the difference between students who are in the open school and students who aren't, a lot of it is they're closing their own gaps and they're solving their own burnout problems. There's so many tools in the open school for these students, and all of this is free. You can look at videos. We just made a video with Dr. Mike Evans, a GP from Toronto. And again, all of this is online. They're tools that you can take back and use with your team to build improvement skills. You can take Helen Bevan's Fundamentals MOOC, or you can take IHI's MOOC. We've been just working on a MOOC with the University of Florida, and we had 6,800 students from 150 countries working on improvement. All of this is free. We're working with Harvard right now, Harvard School of Public Health and Harvard X to make a MOOC. And we expect in the fall that we'll have about 40,000 of you, people who are out there taking care of patients, in the MOOC learning improvement. And again, this idea of democratizing improvement skills is so important because it prevents burnout. It allows you to get in and solve the problems that are so vexing in today's complex world. So build your own improvement skills. And then secondly, I would ask you to think about the systems you're working in. There's a recent article in the BMJ talking about fix and forget. And what I'm going to ask you to do is to move from fix and forget to see, solve, and share. Fix and forget is individual heroism. It's how we all learned in our professional programs to be. You go in to take care of a patient, and there's a problem, and so you fix it, and then you grumble, and then you go back to work. And tomorrow, the same problem is going to pop up for the next person who's taking care of that patient. Fix and forget is a formula for demoralizing staff and for burnout. But what I'm going to ask you to do is use those improvement skills to see, solve, and share. You see a problem, you solve it, but then share it so that the system can be fixed for the whole, so that we're not living in the same problems day after day. My niece just graduated from college, and she took a job at an academic medical center in Boston. And she was working at the medical center for only a few weeks, and she saw a checklist. And every day at the change of shift, there would be a handover process. And the handover process would be between doctors and nurses, between residents and attending physicians, between one shift and another. And they had created a checklist to see if the handovers were going well. And every day, religiously, someone would stand there and check off all the defects that happened in the handover. And then they would take the piece of paper and put it into a drawer. And nothing ever happened with that. So my niece created an app. She took her cell phone and she made an app that aggregates all of the defects from the handover so that they can fix the system for a whole. That's what I'm asking for you to do, is see and solve, but then share so that we're fixing for the whole. Steve Spear, one of our senior fellows, also teaches at MIT, and he's working on developing an app also called See, Solve, and Share. It's a very simple tool where you can, if you see a problem, you open up your cell phone and it will ask you, were you a doctor, nurse, pharmacist, other clinician? You hit the button. It will say, is this a medication problem, a technology problem, an equipment or supply? You hit the button. Is it broken? Is it not sterile? Is it not available? You hit the button. And then your phone camera opens up and you take a picture of the defect, which goes immediately to an aggregate source so that we can fix it for all. And I think this is going to go so far to helping us move away from fix and forget and then create systems for the whole. At IHI, we used to have a wall that was covered with a big piece of paper, and we called it the grr wall. And it was all those times during the day when you sit there and say, grr, if only this didn't happen to me again. We said, write those grrs on the wall so that we can see, solve, and share. And I think the idea here is to use your improvement skills individually, but to use them to fix the system. And then the third improvement skill I would ask you to think about is learning to ask, as Susan Edgman-Levitan would say, not only what's the matter, but what matters to you. And a lot of times people who are burned out or overtired, they're afraid to ask that question because they're afraid that it's going to open up a whole big request that they don't have the time to deal with. And we're going to come back to this in a few minutes so that I can show you how powerful it is when you build on your own improvement skills, when you build on see, solve, and share, and when you learn to ask this question, not only to patients, but to your staff. These three tools, I think, in your toolkit are going to be tremendously powerful in really helping you to create joy and building on resilience. So the third of the tools that I'm going to offer you up this morning is this one, and this is teamwork. Improvement is almost never individual work. Almost always, it's going to require us to work in teams. And I'm going to suggest to you that you think very hard about how to create the best and most vibrant teams. When you can get a great team, you can solve any problem. And I think sometimes we're passing in the night, and we're working with so many different people that it's a challenge for us to build this sense of teamwork. But I want to show you how powerful it is. This is an example from Saskatoon in Canada. And there was a team of people who each one had their own individual knowledge, and they were every day struggling with flow in the hospital. Some days seemed okay and some days weren't, but they had no way of using data to predict, and they had no way of using a team to prevent problems. So what I'm suggesting is, how do we use predictive modeling? How do we use teams to prevent? And this is what they did. I thought this was brilliant. What they did was they created an algorithm, and they were using the data that's in everybody's heads. So one person knew what the admission rates were going to be. Another person knew how many surgical procedures were booked on a given day. Someone else knew what the weather forecast was. Somebody else knew how many influenza cases were in the community. Somebody else knew about staffing, and someone else knew when the holidays were. So they created an admission-discharge ratio that would tell everybody in the hospital, is this going to be a sunny day or is this going to be a cloudy day? And so when you look at this ratio, as an example, today, April 1st, the admission-discharge ratio is 102%, 48 admissions and 47 discharges. Now, just posting it like this lets everybody see we're going to have a day that's going to be busy. So that allows them to huddle in the morning and predict where should we put staff, what kind of changes should we make in order to make sure that the day goes as well as it can. Everybody had bits of this knowledge, but nobody had put it all together until they created this ADR. You can see Sunday's going to be a cloudy day. That allows them to huddle in the morning and make plans for smoothing flow so that every patient can get the care they want and need exactly when they want to need it by using all of this. And most of the time, I find that this is knowledge that would be wasted otherwise. I'm calling it no waste, K-N-O-W-A-S-T-E, no waste. It's all the knowledge that somebody's got in their heads, but we're wasting it because we're not huddling and working effectively in teams. A second example is from my hometown in Boston. Now, you might have heard that we had one hell of a winter. We had almost 2 months when the temperature never got up to freezing. And we had 4 times the snow in our city than we've had in a normal winter. So it was something else, I'll tell you. And I was watching how the hospitals were managing flow in these circumstances. 3 different case studies I'll give you. The first one was one of the major hospitals in the city normally admits and discharges 110 patients each day. Now, with this kind of snowfall, and with the governor sometimes calling a state of emergency, what happened was they only were discharging 10 patients a day. Now, they weren't admitting 110, but they were still seeing a lot of patients come in. Snow blowing accidents and back sprains from shoveling and regular emergencies. So what was happening was the response was basically, oh no. Every day, more patients would come in, fewer could go home. There were patients in the hallways. The staff was working overtime. It was really a very difficult situation that burned out the staff really badly. And I think it's because basically this hospital decided that it would just let things happen at their normal course instead of doing what the second hospital did. The second hospital right down the street looked at weather forecasts. They did a little bit of the ADR kind of forecasting. And they said, with weather forecasts like this, patients are not going to be able to go home. Likely patients, not everybody will make it in. But what they did was they canceled many elective surgeries. So they could manage all of the patient load that they had in a very safe and situational environment where the patients were where they needed to be. The third hospital I thought was really innovative. They, again, were looking at forecasting. They were taking a page out of Saskatoon's book. And what they did was they rented utility vehicles. And they hired all of the off-shift EMTs and ambulance drivers, and they brought them in to take patients home. They got these patients where they wanted to be. These patients were desperate to get home, but they couldn't go by themselves. The EMTs came with the utility vehicles. They brought the patients, often stopping at the supermarket or the pharmacy on the way, shoveling for the patients, and getting those patients home where they wanted to be safely with their families. So they managed the admission-discharge ratio in a very different way and produced really wonderful flow by being innovative and predictive and by using teams that perhaps you might not have thought of before. So I think what we're thinking about is using teams in different ways. And I'm going to suggest to you that you think, when you go back, what are your team huddles or your team meetings like? The staff I'm talking to, who are burned out, they look at me like this. They say, yet another meeting. And they sit in meetings all the time looking backward. If you think about it, think about the last meeting you were in. Are all the tenses past? Are you talking about all the past problems of yesterday? That is a formula for burnout. But what I'm going to give you is a formula for building resilience and joy. And that is to think about your huddles, your team meetings, by coming together with an agenda that has 3 things on it. First, innovation. Second, spread. And third, exnovation. And if you start to build your team meetings so that you spend a third of your time on innovation, a third on spread, and a third on exnovation, I guarantee you will make incredible progress in improving quality and inspire joy. So innovation, what's that going to take? It means that you come together and you say, in this part of our work, we need something brand new. We need a new model. The current system isn't working. And so you're going to want to reach outside and do something different. That's a process that's going to require you to learn a new skill, to run an innovation lab, as an example. Or Kedar Mate and Lindsay Martin from IHI are here that run our innovation ring. You could talk to them and put your problem in their pipeline and have them run an innovation cycle. But we've got lots of new methods and ways to innovate. What this requires is a new design process, or it's harvesting. You might give one of your staff, a physician or a nurse or a medical student, a ticket to go visit another place that's doing something much better. But without innovation, you're going to be churning through the same problems every day. Innovation is a process that brings joy to the work, because the changes, especially if you go outside healthcare and bring new ideas in, are profound, and they'll help you to solve some of these intractable problems. The second is spread. People get demoralized when they see variation in performance. One unit has eliminated C. diff or ventilator pneumonia, or they've managed flow and access, but others haven't. And what we find often is that spread within an organization is tough. So that's going to be a job for your team. When you come together, look at transparent data and say, where is the best we're doing? And how do we close that gap? That's going to require you to look at that data, to create some new ideas and improvement capability, and to have a spread model so that you can begin to close those gaps. I guarantee you, when you start to close those gaps, it brings joy in work. It's demoralizing when you show the data and tell people fix it, but when you come together as a team and you decide this month we're going to close this gap, and you build those processes, it's so joyous. And then the last is exnovation. Exnovation is stopping all the wasted junk that everybody's doing. In healthcare, we have a horrible time with exnovation. You sit in a meeting and talk about what are we going to stop, and people don't want to stop. They're still buying the forms from 30 years ago. They're still doing the same procedures. We keep adding and adding and adding, and that's taking joy out of work. So I would say a third of your agenda should be exnovation. It's going to be what processes, what meetings, everything. What are we going to stop in order to free up energy and resources so that we can move forward and make the improvements we want? And this is going to take courage because we're so not good at it. But I think when you start to create an agenda that looks like innovation, spread, and exnovation, and you start to make the kind of progress that I know we all can in teams with improvement and with curiosity, we can start to close some of these gaps. Here's an example. We just launched the IHI Leadership Alliance, and this is 40 pioneering organizations that got together. I was just last week with them in San Francisco, and we said we need new models of care. They call them radical redesign principles. And they're looking at all of these different ways to provide care. The redesign principles are things like move knowledge, not people, or make it easy, or looking at cultivating joy in work. When you're designing a new process, does it bring joy? And at the end of the first day, we said, boy, what do you think? And the people in the audience, the people who are doing this said, we're not being radical enough. We need to really inspire more radical thinking. Tomorrow, Sanjeev Arora is going to talk here at the meeting about Project Echo. And when he got up and talked, everybody said last week in San Francisco, that's radical. We need radical redesign in order to come together and make the changes. And I wish we were talking about really huge amounts of change, but there was joy in the room because one, they were together, and two, they had some design principles. They were looking at exnovation, and they were putting it all on the table. Here's an example from Salt Lake City in Utah, Primary Children's Hospital. And these doctors and nurses take care of very, very complex kids. In this particular clinic, it's the sickest of the kids. And what they were doing in the old days was they had meeting slots, appointments, and they would churn the patients through. What they found is that the sickest kids, they never got to the end of the discussion. They couldn't really ask what matters to you because the time slots were so tight. So they did a radical redesign. And now for the sickest kids, they have appointments that last an hour or 90 minutes. The patient is there with the family, the doctor, the nurse practitioner, the nurse, the pharmacist, the dietitian. Everybody's in the room together. What they're saying is what matters to you. And what they're finding is with fewer visits, they're taking care of the patient's health care and they're taking care of the patient's health. They're finding that by having longer, more intense visits with those kids who need it means that 2/3 of the day is taken up in those slots. The other 1/3, they're providing radical redesign for patients who aren't that sick, and they're doing phone care. They're texting the kids. They're FaceTiming them. And those visits are much shorter. But what they're finding is that all of the kids are getting to what matters to them, and that is that they can go to school. So it's really flipping care so that the sickest kids get team care, and the kids who aren't so sick get text care, and everybody's loving it. Another example is from Houston, Texas, where firefighters and EMTs are now carrying iPads. And when they respond to an emergency, oftentimes an elderly person who's feeling unsure about their health, they do the normal vital signs, but then they get the patient on FaceTime with a doctor. And that doctor's available 24 hours a day, and the doctor can actually have a coaching session with the patient. What they're finding is that many of the elderly don't really need to be transferred to the emergency department. In the old days, it was EMTs went to the home, put the patient in the ambulance and brought them to the hospital. Now, this interaction on FaceTime is producing many of these visits where the physician will say, "You're fine, I'm gonna have an appointment for you in 2 days' time. I'll send a taxi or a car to bring you to my office." And what we're finding now is that the patients are able to stay home, which is what matters to them, when they get the kind of coaching through an iPad with an EMT in the patient's home. Here in England, in Bradford, All Together Better is looking at new teams with young people using social media to talk and inspire their colleagues about health. And elderly, the seniors lead the way, working with the Bangladeshi population to help people to understand that new teams can come together and create a new vision of health. And I do think we need to put the patient we need to create better teams in order to decrease fragmentation on behalf of the patient. Recently, I was talking to a colleague, and he was describing his experience as he's going through treatment for prostate cancer. And I asked him what his experiences were, and he said that there is no team. And I said, "What do you mean?" And he said, this is what it looks like to him. He has 5 different clinicians, and he said each one of them is giving him dramatically different advice. And those team members have never spoken to each other. This patient is the person who's got to migrate between different points of view. And so I said to him, "What are you going to do?" And he said, "I've made my decision. I've looked at all of this data, all of it conflicting. And I said to myself, what matters most to me?" And he said, "Nobody has ever asked me that." But he said, "I thought it through, and I made a decision based on what matters most to me." And he said, "I'm happy with my decision. I think it's the right one for me." But he said it was hell to get here. And I said to him, he was a little disconcerted at the end of our conversation. And I said, "What's the matter?" And he said, "I have to go see my surgeon in 2 weeks' time." And he said, "I didn't take his advice." And he said, "I don't think the visit is going to go well." So that's the opposite of teamness. And I think we owe it to our patients to defragment, to bring all of these aspects of care together. I'm seeing incredible new models of dental care where we put the teeth back into the patient. And doctors are doing fluoridation, and dental technicians are taking blood pressures. This is putting the patient back together again. Again, here in East London, this team is just blowing my mind in what they're doing with mental health care. They're working with some of the sickest patients with mental illness, and what they're providing is care that's safer and it's more effective. They've done some financial studies to prove it's more cost-effective, and it's more person-centered. So they're producing much improvement toward the triple aim in a very challenging population. But the thing that I think is most inspiring is as they took on this very tough challenge with a very difficult population and they learned improvement skills, you're looking at the workforce with the highest employee satisfaction rating in the country. When you pair improvement skills with tough challenges, you find joy in work. So I think that improvement skills are going to be critical for us all. And as I wrap up, I want to give you the 4th tool in the toolkit, and that's taking care of you. I know I'm up here talking about a lot, change. And you might be sitting there saying, "I'm already too busy. I've already got too much on my plate." But I'm asking you to stop and take care of yourself. In the United States, a few months ago, we launched a new project called the 100 Million Healthier Lives. And what I'm going to hopefully challenge you to do today is to think about how do we begin this 100 Million Healthier Lives campaign with us. Here you can find Shoma Stout, who's leading this project work in the United States, and we're hoping to go global in the next year. Now, you might think it's a little funny to have an American standing up here talking about health, because I know we're not the healthiest nation in the world. but we are looking to learn, we're looking to work. And I think that here, what I'm seeing in the United States is when organizations, healthcare organizations, are taking on the challenge of health for us, they're finding not only health, better vibrancy in the workforce, but they're finding joy in work and great financial results. So this is Health Partners out in Minnesota. Several years ago, they created a program that said they wanted to have the healthiest workforce in the country. And it's really amazing to look at how they define health. It's well-being, it's resilience, it's do they have a stable job in the health system? Can they look to a future? So they defined health and well-being in the broadest way. And what they're seeing over these last years is dramatic improvements in health, which means presenteeism in the workforce. And when their own workforce is healthy, they can take better care of their patients. So their care is getting better year after year as the health of their employees gets better year after year. So I'm going to suggest that we take care of ourselves, that we think about us. If we can create health in ourselves, we have a much better chance of getting the best care to patients. We are on a global learning journey, though, and a few weeks ago, I was on the phone with our 100 million healthier lives, and I came across a story that I want to share with you. It's from Scotland, and Pat O'Connor's sitting right here in the audience, and so I hope you can find her. And Elaine Wiley is my new hero. So here is a story from a school in Scotland that we broadcast to the 100 Million Lives campaign. And it's a story about an improvement project. There was a teacher, Elaine, working with the teacher in the school, who was sitting there and looking at her class. And she has a wonderful volunteer. He's 81 years old. He's a very prestigious guy in this part of Scotland who comes to school every day, and he teaches the kids penny whistles, he teaches them poetry. He's giving back at 81 years in the classroom. And one day he was sitting in the classroom and he looked out and he said, you know, these kids are not fit. He's teaching them intellectual assets, but he said, these kids are not fit. He said, they're fat. And so the teacher said, well, I wonder, can I do a PDSA? Can I do a Plan, Do, Study, Act? So she got a small group of the class and she started to run them outside on a little pathway outside the school. Now, Derek had to translate this for me because he said that they couldn't run the length of themselves. And that's not an American expression, so I had to ask Derek Feely to translate, but he said that means that they can't make it very far. They couldn't make it far at all. So the teacher started running PDSAs. And eventually she got to the daily mile where every kid in the school goes out and runs 5 laps around this pathway. 5 laps is a mile. And these kids go out in almost every single kind of weather. They don't change clothes because if you let them change clothes, then that would be another half an hour. But now they can do this in 15 minutes. The teachers are loving this, and this is free. So what they're doing is they're getting every kid to run the daily mile. It's so embedded in the life of this school that they're now linking it into the curriculum. So in geography, they teach the daily Nile, and they're teaching math by looking at how do you measure laps around the track. The measurement, each kid has their own measure. You can see this little girl has 5 blocks that she'll put together, and that means she's run her mile. The impact is amazing. It's inclusive of all children. Everybody does this. The teachers say the kids are improved in their focus, they can pay attention. If they have an issue or a challenge, oftentimes they'll be running alongside the teacher outside, whereas they might not have the courage to approach the teacher in a classroom and be seen by the rest of the classes needing help. So all 420 of these children are fit. Not one kid in the startup class is fat. Not one kid is overweight. And I think that is brilliant. The parents just love it. The parents are now pushing to have it be the daily 2 mile. They said the children are sleeping better, they're eating better. Now the parents are having running clubs, so as always happens, the kids are transforming the parents to better health. And the teachers say they love it too. They're out there and they're exercising. They said the kids have better attention span, they're socializing better, there aren't as many cliques. There just couldn't be, I don't think, a better outcome. And so you look at this school teacher in Sterling, provoked by the volunteer, one person who starts running one PDSA, and here's a school teacher using PDSA first in her classroom and now across the whole school. And you see, not only is every kid fit, but what these teachers have done is they have not only improved health for these kids today, but they've bought them 70 years of better health. These teachers have done more for health and healthcare than we could do in any number of visits in the course of a year. So I inspire you to think about us. What could we do? Could you get a daily mile going in your hospital? Could we start to think in a very different way about building joy and resilience in our workforce? Because I am convinced that this kind of an effort is going to produce better health, better care, and help us to move along. So the essence of the change I'm asking is this. It's keeping people well and keeping people whole. It's really thinking through, how do we support health and well-being? It's thinking about making it easy for people to do the right thing. And when needed, people may have to get to the hospital. And when somebody gets to the hospital, that they get the very best care. I want to wrap up this morning by sharing a video with you of a friend of mine who I think is really going to help students in a very different way. What he is talking about, I nicknamed him a few years ago, the doctor for your soul, because, and I think you'll see why in the video, but in this video, he's not only taking incredible care of a patient, but he's teaching students that you can open up and you can ask what matters to you. So we'll roll this little video.
Doctors and hospitals really aren't what we call conversation ready, because we ourselves have so medicalized everything that I'm seeing for this patient. What's the dose of this medicine? What's the chemotherapy or not? With this test or not? That we ourselves don't actually often have the experience, the practice, the support that we need to sit down with a patient as a human being, understand what's important to them as a human being, and make sure that that's always at the center of every medical plan. I was asked to see Thelma Patello. All that I knew was she was a 92-year-old woman who had severe vascular circulation problems in her leg, causing her lots of problems, for which there wasn't going to be any effective treatment that they could offer except amputation, which she just refused. She wasn't going to have that done. And so they said she didn't have that long to live, and so they wanted me to come by and maybe talk to her about hospice kind of options.
What I remember, I guess most strikingly, was that Dr. Farrow asked her, what would be a good day for you?
And so I sat down on the bed. I said, getting to know you some as a person will help me figure out how I can best help you.
And it's such a simple question. What would be a good day for you? What do you like to do? These things that I don't feel like I have time, honestly, on a daily basis when I'm seeing patients, when I'm on call, to ask these little things.
In whatever time there is ahead for you, how can we make that as good as it possibly can be for you? Singing is what made it a good day.
But it didn't take that long to find out that this is what was important to her.
I said, when was the last time that you sang? And she just sort of said, I haven't sung in a long time. I don't sing anymore. I said, why not? And she kind of looked at me and I said, how about singing me a song?
I see trees of green, red roses too. I see them bloom for me and for you. And I say to myself, what do you say, darling? What a wonderful world. Somebody, where's the drummer?
I see skies of blue.
I see skies of blue.
Clouds of white.
Clouds of white.
The bright, blessed
The bright,
days.
blessed sun. And the dark, sacred night. And I think to myself, what a wonderful world. And I think to myself, what a wonderful world. Pop, 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 pop. Oh, yeah.
And it made such a huge difference in her day.
The music was right there as vividly as it had ever been. And every time her voice started to sing, you could just see her eyes getting younger, her face getting younger, and a kind of human joy returning.
So when you go back in, isn't it wonderful? Dolly, in my mind, Thelma Botello, Dolly Baker, is, I think, one of the coolest people on earth. She was singing jazz around the world. She was confessing to people making the video that she had a big fight with her husband because he had an affair with Marilyn Monroe. So when you walk into the next patient room, I want you to ask yourself, is this a 92-year-old lady with leg ulcers, or is this the coolest woman on earth? Because I think she is. So I guess I want to wrap up by saying that sometimes it's scary to ask what makes a good day. As the resident said in the film, I sometimes think I don't have time, but it's so simple. And what you find is when you reach out, when you give love, you get love. When you reach out and take care of someone, you can do that better if you've taken care of yourself. So I would suggest that you start to think about these tools. Start to think about how can you build curiosity. Stop and ask what makes a good day. Think about your own improvement skills. Think about not fix and forget. When you feel that grr rising in, say, see, solve, and share. I need to figure out how do I solve this for tomorrow. Think about innovation and spread and exnovation. And the exnovation part is going to be the most fun when you build up the courage to start stopping things. And then think about yourself. Are you healthy enough? How can you as a leader create a healthy team? How do you begin to work on all of these aspects of our tremendously challenging life so that tomorrow or the next day, when you go back to take care of patients, you're quite comfortable to walk in and say, what makes a good day for you? Thank you.